Welcome to Podcasts on Demand, a continuing medical education activity. This activity includes the most recent and current clinical data presented by leading experts.
Well, we're back. It's Mike Gibson, Manesh Patel. This time we're focusing on what we're learning from clinical trials. It says a deep dive here. I don't want anyone to drown in a deep dive. I'm going to kind of go the right depth here so that you can understand where we are and where we're going with all the very rapidly emerging clinical trials data. This is overwhelming. It's good in a way, though, that we have so many overwhelming trials and choices ongoing right now. There's research in total knee replacement, heart attack, atrial fibrillation, stroke, cancer, renal disease. A lot of action in the total knee replacement space. This is where we figure out what the right dose for these medicines are. This is where we figure out, can we reduce both bleeding and efficacy? And I got to say, the good news is on the total knee side, it looks like we get a free lunch. With this new class of agents, Factor XI inhibitors, we reduce bleeding and efficacy compared with an active drug like enoxaparin. Lots of heart attack patients out there. They're going to face about a 10 to 20% risk of having another heart attack. What can we do to reduce that? And that's an area of active investigation. Atrial fibrillation, growing population, going to be a growing unmet need. And we have many trials ongoing. We'll hit those. If you've had a stroke, we would like to prevent a subsequent stroke. So there's secondary stroke prevention trials ongoing. Cancer has a lot of clotting associated with it, and there's multiple trials targeting that. And finally, we have a lot of tubing. We have a lot of foreign bodies in the patient's body in end-stage renal disease. And that's a disease state where we have a lot of intrinsic pathway activation and extrinsic. So again, another area that's ripe for studying. Let's start with an easy one, total knee replacement. Here you can see 4 different trials done, 4 different approaches, 4 different drugs, all yielding the same kind of answer that the Factor XI approach is superior to enoxaparin in venous thromboembolism. Remember in a prior episode, we said the venous system is the center of the bullseye for this class. You really see a very pronounced reduction in venous events in genetics and epidemiology where you have Factor XI deficiency. And bleeding, a win with all these approaches versus enoxaparin. This is what we're going for. Less bleeding, less ischemic events. That's the holy grail. It looks like we nailed it on the total knee replacement side. And that's why people were excited about this class in general. This is, again, a very confusing slide, but basically all of our DOAC choices tend to be better than warfarin. The DOACs are fairly similar in the total knee space, but it does go to show you we have some better choices than enoxaparin and warfarin in this space. Now, let's talk about atrial fibrillation. Manesh, you're very involved in the Pacific program. The program there, that's where you look to see, can asundexian reduce bleeding? It was a phase 2 study, a safety study, and you did see less bleeding with asundexian. Azalea, a different drug, abelacimab, a sub-Q drug that's given once a month, an antibody, also against an active comparator, this time rivaroxaban, 67% reduction in bleeding. So whether you go up against apixaban or rivaroxaban, these 2 Factor XI inhibitors showed safer results, less bleeding. And again, in AFib, that's one of the things we want to reduce, both GI bleeding and hemorrhagic stroke. Those are 2 of the real problems. Both of them can be fatal and disabling. Now, moving on to phase 3, Manesh, you led a great trial, the Oceanic AF trial, comparing asundexian to apixaban. Very important. These trials are going up against apixaban, which is a very safe drug in this setting. But You showed less bleeding, again with the factor 11 approach with asundexian. Didn't quite make it on the efficacy side, inferior efficacy results. We'll circle back to that in a moment with a little deeper dive. Two other studies are ongoing, one with abelacimab, compared to placebo, not going up against an active drug. These people are people who the doctor said, you know what, you're not even healthy enough to get a haircut, let alone be on warfarin. So these are people who are getting too sick to get some of our current therapies, but let's see if abelacimab offers an alternative. And finally, with milvexian, going up against apixaban in atrial fibrillation and something called Librexia AF. Let's look first at what was done with asundexian. Three main areas of study: AF, AMI, and stroke. On the AF side, the phase 2 study set the stage for the dosing that you would use in your phase 3 trial. You went with the highest dose from that study, the 50 milligram once a day dose. Specific AMI, I find the most noteworthy thing from this is that on top of a lot of people getting ticagrelor and aspirin, there was no increased risk of bleeding. So I thought that was very important for the class to say, look, on top of aggressive antiplatelets, we can have some safety. We'll see what happens, whether Bayer and the sponsor elect to pursue that indication. And Pacific Stroke, I found this to be one of the most important phase 2 studies. Taught us a lot. You know, we went to the FDA in the past, Manesh, to say, can we use imaging endpoints instead of clinical endpoints? And the FDA wisely said, no, we don't know what, quote, Swiss cheese means in the brain. I'll never forget that quote. And it turns out that, you know, there really wasn't much benefit with respect to the imaging endpoints. But here's what I thought was most interesting. When you lump recurrent stroke and TIA together in a modest-sized phase 2 study here, 1,800 or so patients, there was, you know, a trend towards a benefit. So that, I felt, gave this class a shot in the arm on the arterial side, that maybe we could do something good on the arterial side. The phase 3 study of asundexian in stroke prevention, recurrent stroke, is still ongoing, has not been stopped. This is the bleeding data. On the far right, you see apixaban and the bleeding risk there, and you see either 20 or 50 of asundexian was safer, significantly safer compared to apixaban. And that's what gave us so much excitement from the phase 2 and encouragement. Now here, it's a little embarrassing presenting Oceanic in front of Manesh, who led the trial. Big trial, phase 3 trial, international, double-blind, randomized, 14,800 patients with AF, very well-conducted trial. The primary endpoint was stroke or systemic embolization, common endpoint used over many years in many trials. The primary safety endpoint was those major bleeds, those ISTH major bleeds. And of course, those were lumped together for a composite or net endpoint. A once-a-day dose of the high dose of 50 milligrams of asundexian was studied. That was compared to a good drug, apixaban, 5 or 2.5 milligrams twice a day. That's a twice-a-day dosing of that, but once-a-day dosing of asundexian. Now, the IDMC said to stop the study in November of 2023 due to inferior efficacy. And we'll look at those curves here in a second. And I got to say, when I saw this, I was somewhat shocked. I'll be really honest. Apixaban was superior to asundexian at a dose of 50 milligrams. What was interesting to me, Manesh, was the curve split very quickly, you know, and Boy, that was a real head scratcher for me. There was a little bit of a shoulder to that curve of asundexian, which is a little high risk very early on. We often say that, this was just maybe a dose issue, but it made me, concerned about, that initial period. Manesh, what are your thoughts about the shape of these curves and why we didn't see better efficacy?
Yeah, thanks, Mike. It's obviously we'll never know the answer outside of the observation, but and it's always humbling when you do large clinical trials and they don't show us the answers we think. Gets us back to why we do the trials. But they teach us a lot of things that we're going to learn, I think, as we go to improve the field. And I often say, as you've showed in other talks and timelines, that antithrombotics have been evolving over 50 years, and I wish they evolved faster. What we learned in this trial, I think, in these curves might be, I've sort of said it's, I think, three parts. One is, at least in this population, the dose of asundexian compared to apixaban may not be sufficient. The second is that we're learning that people that have been on these therapies for quite some time, like people that were not naive to apixaban, about 82% of the people here were on DOACs or anticoagulants. Coming into a trial, they're unlikely to have a high event rate. As you can see, the apixaban arm, not only is it lower, but it's substantially lower than what would be anticipated for the risk of the population. So that's the second lesson, which is they're responders. And then the third, which speaks to the curves, in addition to dose, there may be a component of I'll call it a transition cost. So if you're stable and not having a lot of event rate on an anticoagulant, and you bring that person into a trial and transition them, then even when in the best case scenario, we have to know that it may be a combination of transition and transitioning with not the right dose. So we've sort of said three parts, right? A responder population, a dose, and a transition. Those three things probably lead to the findings that you see.
Yeah, I mean, think about it, Manesh. If you're tolerating apixaban well and not bleeding, not having any efficacy, I mean, you've passed the bleeding stress test, and you've declared yourself a low risk patient. So if you had to do it again, and I bet we will do these kinds of trials again, would you really enrich for people who had not been on a DOAC in the past?
Yeah, in fact, we forget we have this group called the Combine AF group, which is put together the 4 randomized trial data sets, and it's interesting when you look at that paper that Tony Carnicelli is the lead author on. Well, the first analysis of which you identify in those trials, by definition, because those trials, the DOAC initial trials, were going up against warfarin. On average, 43% of the patients were naive to oral anticoagulant, meaning they haven't had it in some amount of time. We'll call it 6 weeks to 3 months before coming into the trial. So the DOAC trials were a closer comparison to warfarin in that a substantial number of those patients, by design and rely, 50% were naive or not previously treated with an anticoagulant. I think in apixaban and rivaroxaban trials, it was in the 40s, and similarly in the edoxaban trial. So I think, 15 years later, what we find is that more people are treated, especially when we're bringing them into trials. So one of the things we likely do on future studies is to ensure that there's more oral anticoagulant naive patients, or at least patients that haven't been taking it for greater than a few weeks to a month or two, but not patients that have been on these therapies for 6 months to a year or several years, because I think that then, as you said, highlights individuals that are responders, low event rates, unlikely to bleed. The total trial event rate goes low. It might show non-inferiority, but it becomes really hard to show other things too. So it's just a complexity that you want to try to avoid if you can. Makes the trials harder, but these are the kinds of lessons we learn.
Yeah. I mean, and I said they'd passed their bleeding stress test, these apixaban people, but asundexian was still safer in people who passed their bleeding stress test. I thought that was interesting. When you look at that efficacy asundexian curve, how would that compare to placebo? I mean, is there any activity there, or was this, a Diet Coke,
Yeah, I've gotten that asked question too. And I think the answer is, again, we would expect that there's activity there. People have concern just because of the event rate and what they see. But for this population, the expected naive or not treated event rate is higher, substantially higher again. And so we think there is an efficacy here at that dose. And so I think there's a valuable opportunity for us in this class of therapies and certainly this pathway to identify the right population with the right strategy. And one might think that as you go forward with the trials you're looking at, that we're seeing that. We're seeing that LILAC, as you highlighted, is evaluating people that can't be on any of these. I'll call those failures. So then you go up against placebo. Factor 11 has a pathway. And I think in the other study, Librexia, or in other studies, people might say you're going to go up against apixaban, hopefully with, as you said, get the drug with the right dose and those things, but also potentially identify populations that may be a little bit newer to it so that you can identify ways that you can find a difference.
Well, we'll reload. We got to find the right dose for the right patient at the right time for the right duration. And we learned a lot of lessons here. Just a few comparisons between the milvexian study in AF that's ongoing and the Oceanic study. A little higher dosing for the milvexian molecule studied over a greater dose range. You used the actual population, an AF population, to find your dose. A total knee replacement population was used to find the AF dose. And we also used PTT data for milvexian, although, the PTT for one drug may not be the same as the meaning of the PTT for another drug, and some meta-analytic data. There was an assay that was used for asundexian, assay developed specifically for this. And with milvexian, the dosing is twice a day. With asundexian, it was once a day. Once a day dosing is like my medicine. I remember to take them in the morning. They're a convenience, and you remember it. But twice a day dosing gives you a little higher trough levels, and that may be important in terms of efficacy. It may give you a little more bleeding, we'll see. So some differences in the designs and doses of the study. So, so in Oceanic, you and your investigator showed reduced bleeding, but inferior efficacy. So how do you weigh bleeding risk and, efficacy risk? How does this change your perception of how you treat high-risk patients today?
Well, I think, Mike, as we had a great conversation about, I think the way I think about existing trial results and where I think the therapy is going in atrial fibrillation, but also for secondary stroke prevention, is that for our patients, there are two big classes in my mind. Those that are not able to or doing well with current therapies. And those are going to be people who are already underdosed, people who are stopping therapy, people who feel the bleeding risk is too high. There's a clear direct opportunity with new therapeutics, which we should, as we are, study and understand. There's still even a bigger opportunity, I think, for people who are failing existing therapies when they're first started with that, or they're just going in that pathway. And those are the people we've talked about where within 6 months, 25% stop, or after a year, they've had a bleeding or a stroke event. And so the secret sauce for us is to sort of get that fair fight going with, I'll call it, patients that are at substantial risk of both stroke and bleeding that are getting current DOACs like apixaban, and test that against, I guess, best strategy, anti-Factor XIa inhibition.
Well, you and I have used the balance beam kind of analogy in the past. So maybe if you are on a 4-inch balance beam and you've been falling off, maybe this new class of drugs is more like an 8-inch balance beam or a foot, so you're not going to fall off on one side or the other. So different balance beams for different patients. We'll see how it all plays out. Let's look real quickly at milvexian. The phase 2 program was really a secondary stroke prevention trial, 2,300 patients there, a knee trial. These two studies informed the dosing that we're using in phase 3. So there's a stroke trial, a secondary prevention stroke trial, using a low dose, 25 twice a day. That was identified in phase 2 as something that was effective versus Enox, but safe. And likewise, over on the ACS side, we're studying that 25 milligram dose twice a day. I like to say, Manesh, 25 milligrams twice a day is the new 2.5 twice a day of Riva, So this is the descendant of that. Librexia, we're going with a higher dose there. 100 milligrams twice a day, you need a little more protection at those trough levels, so a little higher dose. They're going up against apixaban, so an active comparator. The other two is going up against placebo. Traditional endpoints in these studies, hopefully somewhere around 2026, 2027, we'll see some of the results. In the AF study, it is 100 milligrams twice a day of milvexian, twice a day dosing, different than the once a day dosing for asundexian, hopefully higher troughs. Going against that active comparator, the primary endpoint will be non-inferiority for effectiveness versus apixaban, and then superiority on bleeding. So we want to preserve the benefits of the DOACs, but make a safer alternative. The total need results were used to figure out the dose here. Let me direct your attention to the twice a day dosing. You can see 25 milligrams twice a day was about as good as enoxaparin. But when you look over at the 25 milligram dose, it was safer than enoxaparin. So we're hopefully having something that is as safe or as effective but safer than enoxaparin on those sides. And the 100 twice a day dosing was superior on VTE and superior on bleeding. And that was the basis of the choice of that drug dose for AF. Now, the way it was really done, to be perfectly honest, we looked at, I'm going to say 60,000 patients or something, kind of a network meta-analysis with enoxaparin being the anchor here, and really apixaban being the anchor, and comparing the different drugs to apixaban on the VTE side. And you can see apixaban beat enoxaparin, obviously. Now, when you look at the milvexian doses, at the 50 twice a day, it looks like apixaban may have been better. A tie at 75 twice a day of milvexian, but it was the 100 milligram twice a day dose that looked like it might perhaps be superior to apixaban. So that is really how the dose was most likely figured out. Abelacimab antibody, once a month injection, long half-life, turned out to be safer than rivaroxaban, and the study was discontinued prematurely. They decided to move forward with the high dose of abelacimab because it turned out to be so safe. There was also a recent study looking at people who went on to have a procedure on abelacimab. You might think, well, my gosh, the drug has a 1 month half-life, is it going to be safe? And it turned out to be just as safe, if not safer, than rivaroxaban in people going on to a procedure. So 2% rates of bleeding with Riva and 1.2% in the abelacimab group. So, you can do procedures on the drug safely relative to the other DOACs. So I think we see that these show promise. I think bleeding is easy. We're probably going to have a safer class of drugs. The big question is efficacy. The trials are ongoing. We'll see where we end up in a year or two. So, Manesh, when we talk about minimizing risk, how often are pharmacists or care managers involved in your approach to medicine reconciliation or de-prescribing?
Yeah, Mike, what a great question. And I guess I would say, hopefully more and more, and I'm going to add a caveat here. I fully respect and think our pharmacists are some of the strongest people on our medical team, and we have many more helping us engage in guideline-directed therapy for heart failure and other things. Sometimes what's happening for our patients, or what was happening for our patients that were getting therapeutics and going to fill the medications, our pharmacy colleagues were participating in some of the, I'll call it contraindications, making sure they're getting the right dose, making sure that they're not on other therapeutics. So that's often the case. De-prescribing in this space is often happened in atrial fibrillation prior to Factor XI inhibition sort of introduction, in considering stopping antiplatelet therapy, considering other things that people could be on to increase our risk of bleeding. And I think our pharmacists have helped a lot. I see the future of this, as you've highlighted, Mike, being much more data-driven with a lot of other automated tools to help us with not just dosing, prescribing, interactions, refilling, deprescribing, considering that. So I think those are going to be big tools coming for us. And I would just say this is an area ripe for it because the average atrial fibrillation patient has somewhere between 5 and 10 medications they're taking before you add an antithrombotic. So just thinking about that heart failure patient who's older with some of those other risk factors, and then you add one of these therapeutics, there's a lot there for us to do and to try to make sure that they're taking the right therapy. So it's a really important sort of class of drugs, but it's also a really important group of people, our pharmacy professionals that are helping us with this.
Yeah, we often say we're practicing evidence-based medicine. I hope we do. That's necessary, but it's not going to be sufficient. We also need to practice and acknowledge that we have to practice relationship-based medicine. Our relationship with our patients is so important in terms of this adherence issue. And, yes, we need the data, we need the evidence, but hopefully AI can help with, taking those notes, listening while we're talking to the patient, take all those notes, get rid of us sitting at the computer and typing. So we can free up our time really to talk more to the patient and keep them engaged and improve compliance and adherence. Well, Manesh, thank you so much for joining us. I thought this was a great episode. I always learned so much talking to you, enjoyed your perspectives on Oceanic. Thanks to all of you in the audience for joining us today.
We hope you found this podcast useful and educational.